special treat this week for the Voices of Veterinary Medicine podcast. We have not a veterinarian, but an MD as a guest, and my husband. So this is Mrs. DVM and Mr. MD having a conversation about the difference between being a veterinarian and becoming a veterinarian, or becoming and being an MD. So why don't we start with, do you want to talk at all about like your past, your history?
Oh, sure. Well, the life story is a little challenging, but I did not get along with public schooling or any schooling, and sort of dropped out of high school and pretty much worked on my computer garbage. You know, I was a pretty intense hobbyist way before anybody who had cells or whatever. You know, a computer that displayed, blue letters or green letters was, $4,000. So we happened to have one, and I was very into it, and I was a big computer nerd back when that was actually, a difficult thing to do, not clicky download app on your phone. And not to insult those of us who can barely master that skill, but that's fine.
It's not. This is an example. I think, it's such a cool story because, you're an MD and you went to medical school, but you don't have a high school diploma. You have a GED. So I just want to say,
I have a homeschool diploma because I faked them out and told them I was homeschooled.
Oh, okay. You weren't homeschooled. You just learned whatever you needed to. But then you took the GED.
No, I took a homeschool test, homeschool diploma test for people who are homeschooled.
Okay.
So for all the world, it looks like I'm a homeschooled. It's a harder test. It requires more. It doesn't come with specific training you have to do. You just have to demonstrate proficiency.
Why didn't you take the GED if it's equivalent?
It was a little easier to apply for college with a homeschool diploma than it was to apply with the GED.
Okay.
So,
anyway,
you can get a homeschool diploma and then quietly leave out the fact that you never actually had any homeschooling, and people just assume you did. Versus if you get a GED, it's like you dropped out of high school, got pregnant, and worked at McDonald's for 5 years, and later you got a GED.
So it's perception.
Nothing wrong with it.
Right.
It's,
okay. It's perception. It wasn't that you were lazy. So this is just, I think it's an inspiring story for people out there who, don't do well in high school. And I did not do well in high school. It's because I was bored.
Yeah.
And that's what happened to you, except you did not have I was afraid of the consequences of not doing what was asked of me as a high school student. You were not.
No.
So you were just like, not doing this. This is stupid, and I'm leaving.
Well, there was the story of third grade, which is the last grade that I actually did any homework for.
Yeah.
Or any work at all.
I love this story.
It was cursive writing, right? Yeah. And we did and I was like, oh, this is,
fun.
This is fine. Like you just fill an entire page with A, and then you do lowercase a.
Yeah.
And then and then that was the day.
Yeah.
Right. And then the next day it was B.
Yeah.
I did B and I did lowercase b. And I'm like, I like the novelty of writing in cursive writing, which is something that, was like an adult thing to do, had worn off by that point. And the next day it was C. And I saw where it was going. I could see the next, I don't know. How old are you in third grade? 12 years?
No, that's...
I think you're 10 in third grade.
Yeah, 9 or 10.
Yeah, so the next 9 years of my life being spent doing things just as stupid as that. I don't know. Plus the math was so the math at that, I didn't go to a good school. The math was so easy. It was just mind-numbingly boring. I didn't need 5 pages of worksheets. I didn't need to, read the reading book, right? I was reading actual books made for adults. You don't need, right? So what was I going to do for the next 9 years? So basically I just said, no, no. I can see where this is going, and no. And I just said no. And that was it. I didn't do school anymore.
Mm-hmm.
So, but then anyway, I did my computer hobby stuff. Right.
Mm-hmm.
And I was pretty, all the people who were like the big geeks back then, there were a lot of people like me who ended up doing that as a career for the rest of their life, starting companies, doing things like that.
Right.
And, but at some point it was like the 90s, like early 90s .com thing. Computers are now actually useful for business.
Mm-hmm.
I mean, besides just very specialty areas, they were actually useful. And, kind of they drove a dump truck full of money up to my door because I had all the skills,
mm-hmm.
right? Like there were so few people with those skills.
Yeah.
Computer science programs were all about programming and not doing it particularly well. People who were real hackers, they did it on their own. They learned everything before they even went to college. It was a community type of thing.
Mm-hmm.
And back then there was a big, demand for people like that, right?
Mm-hmm.
If you had that set of skills,
mm-hmm.
Where you could, program, debug, build a system, integrate networking, like that was hard stuff to do back then. It wasn't all like, drivers and toolkits. You were going into drivers to mess with the code so that this card would work with that system kind of thing. And, and that was a valuable skill. So I did it because they were going to pay me and I didn't have anything else to do.
Mm-hmm.
So, but I hated that. Like working for a big company. I worked for AT&T.
Mm-hmm.
Working for a big company like that, there was so much drudgery and boredom to it. There's very little.
We already know this about you.
There's actually very little fun.
Yeah, that you don't like drudgery and boredom.
No,
you can't tolerate it for long.
Or at all.
Yeah. So I guess that makes sense now why you were like, no, I need to go to medical school this year right now.
Went to a 3rd-tier public university in my hometown and did fairly well there. So I could, basically only to get into medical school,
mm-hmm.
Biology, that kind of thing. Was really interested in OChem. So I took a bunch of graduate level stuff in that, and I think that's probably why, despite my having failed Spanish class twice, they did let me into medical school. And what else? Then I applied somewhat late in the cycle for med school, so I didn't get to go to the public university, which is I know a big part of your thing, which is how much debt people have.
Exactly.
So I ended up going to a private university,
mm-hmm.
which was, of course, not as desirable,
mm-hmm.
but it is what it is. And I didn't want to wait a year, which I probably should have. I probably should have waited another year and gone to UW-Madison.
Yeah. Perhaps we wouldn't have met, though, if you'd waited another year.
Oh, almost certainly not.
$400,000? I don't know. I don't know. It's your debt. You tell me.
Yeah, it's
Am I worth $400,000?
It's a big payment. It's a big payment. Yeah. You're worth it, but it's a big payment. So my student loan payment is currently, I think, $4,000 a month.
Yeah.
But
that's a 10-year payoff.
15-year
payoff. Geez. Right.
At $4,000 a month.
Yeah.
So that's, that is what it is.
Yeah.
I had to take a slightly better paying job, which means leaving Chicago and, moving out to Flagstaff, which I love.
Mm-hmm.
And I found a great job.
Yeah. So we moved out here for his job because it's a great job. And I could never make that kind of money as a veterinarian unless I started my own business.
Yeah, you'd have to own a practice.
I'd have to open my own practice.
Yeah.
And it would probably be years before I made that. So tell me about your experience in medical school when you got there. I mean.
Wow. Okay.
Yeah. I mean, when you first started, were you like super excited? Like, ooh, I'm going to learn how to be a doctor or what was going through your head? And what did you experience?
I thought it was going to be much more clinically based than it was. I knew there was all the science courses,
mm-hmm.
but the science courses weren't clinically related as mm-hmm. much as they could have been.
Mm-hmm.
There were some schools that were doing more clinically related curriculums,
mm-hmm.
but it wasn't particularly good. I want to say that there were probably 3 or 4 professors in my first year out of the, 20 we had
Mm-hmm.
that I thought were really excellent teachers.
Mm-hmm.
And I'll leave that ambiguous so they all, if they see this, can think of that it's them. But there were a few that were really good. And the downside was that I had done so much chemistry and bio
Mm-hmm.
that I knew a lot of this stuff already.
Mm-hmm.
Except for just not in, it was like taking the same classes again with more difficult competition.
A lot of people say that. Plus having more material to learn in less time. But a lot of it is like, didn't I just do this in undergrad? Yeah. A lot of vet students feel that way too. But when I was writing book 2 about getting the most out of vet school, you read the book and for me.
Mm-hmm.
And the part where I describe 50% of what you learn in the first 2 years is not really useful. You said, I think it's a lot more than 50%.
Oh, a hell of a lot more than 50%. Like even the clinically useful classes, like anatomy and physiology.
They weren't taught in a way that was useful.
I mean, like there is absolutely no need for me, even as a surgeon, to know even if I was an orthopod, they don't know the names of the ridges on the thigh bone and each insertion, right? I mean, you're talking about like really subspecialties of orthopedics or something that would have to know that.
Yeah.
Maybe sports medicine people know, 100 of them.
Yeah.
Right. So you learn 600 of them. You don't know which are the important ones.
Mm-hmm.
You do the dissections. You don't understand human physiology well enough to understand the dissections because you're starting real early in med school.
Yeah, yeah.
Like you start dissecting the first year.
Same with med school.
And you're like, okay, yeah, that's a nerve.
Yep.
Like, what's that do?
Right.
Do I even care?
Yes.
Why should I care?
Right.
What is which are the ones that I really should be focused on? And if I was there now, I would say, look up the 100 most common fractures and learn where those are and look at them, I guess. Clinically correlate what you're looking at with radiography, because that's the only way you're ever going to see these things again, unless you're a surgeon. And even as a surgeon, most of them you won't.
Yeah.
So you say, well, okay, I'm looking at the tibial plateau in the knee or something like that, and you say, okay, well, what does that look like in radiography? What's a fracture look like?
Right.
Something like that. I mean, because, they don't ask you to do that stuff. They just say, dissect it. Yeah, there it is.
Memorize
There's the ACL.
Yeah. Yeah.
Wonderful. That's the ACL.
And and there's no emphasis like this is a really important ligament that you're going to learn about later. No, it's just bundled in there with all the other insignificant stuff. And I want to
people would know ACL, but like, how about lateral collateral ligament? That's torn all the time too. Nobody would tell you that.
Right. No, they did not. So in my anatomy class, no, we never learned that, this is a really important ligament. And, this is how it works. And, later on, you're going to figure out this is how you're going to palpate it to figure out if it's ruptured or not. That would have been helpful, but no. So one really important example I'd like to give about my anatomy class and not learning the stuff that really would have been clinically relevant is, for instance, when we were dissecting in the abdomen, and we were going over, and I remember, having to memorize every artery and vein that fed the small intestine, the large intestine. And while we were looking at those structures in anatomy lab and memory and taking our lectures, nobody ever said, by the way, later, if you have to do surgery on a dog that has a foreign body obstruction, and let's say it's lodged in the proximal small intestine, so like right there in the duodenum, perhaps, there's a very important structure there that you need to be careful of. You can't just cut through, the duodenum without thinking about it, because what lives there?
What are you talking about?
I'm talking about the pancreatic duct and the bile duct.
Yeah, no, I didn't think it would be that simple. I was like some suspensory ligament. I don't know.
No, it's that simple. It's that simple, you know? I had to learn that later. Like, this is an area you have to be very careful when you're surgerizing, because if you
cut the common bile duct,
Jesus, you're done.
You might as well euthanize for you guys. And for us, I don't know what you do.
Exactly.
So but it's not a good time when that happens. I want to say that though, that the biggest problem, what I didn't understand about med school when I got there was that it was just another, for us, and I think this is a big difference, it's just another, I don't know, your audience is going to be pre-vets and vet students and some vets, right? Mm-hmm. And I think that if you're a pre-vet, once you get into veterinary school, you're really kind of done competing with other people. Is that right? Because like, unless you want like to go and be a zoo resident or something, right?
If you want to do a specialty, if you want to specialize and get a residency, then it's still competitive.
Yeah. For us, it's really only that, because we all specialize, right? There's, family and internal medicine are the ones that people think aren't specialists, but that's a residency, right? That's 3 years each.
All of it is.
Right. So right away you're saying, where do I want to go? Right. What residency do I want to do? I'm going to start competing against these other people for residencies after I just got into med school and just, just completed that era of my life. And competing there is not that hard. It's just mind numbing. Like, you have to just be the type of person who does, who studies all the time. I was never that, not at all.
Yeah.
Like,
So would you say competing against, okay, so why can't you just do your best and hope for the best? What do you mean? Was there like animosity between the students or an adversarial atmosphere?
Not at all. Nobody wanted to be number one. It was good enough to be number two. So like, it's not like we had maybe we had a valedictorian, I'm not sure.
But you couldn't say, okay, like I've known people who got into vet school who are like, okay, and now I'm done working my butt off because I'm in vet school and I know that when I get out, I'm not going to specialize. You couldn't be like that.
You can. Then you'll end up doing a, non-specialty residency in a non-university hospital. And doing a non-specialty residency like internal medicine or family medicine in a non-university hospital doesn't get you the training that the university hospitals do, right? And it doesn't get you, depending on what you want to do with yourself, you might not be able to get to where you want to go, right? Like, and another thing that people don't realize is that residency isn't the end either, right? So you compete with everybody to get into med school. You compete with everybody in med school to get a residency. And then you're really actually competing with the people in your residency to get fellowships, right? Because all of the internal medicine specialties, cardiology, gastroenterology, these things make, the people who do the cardiology and internal and gastroenterology, I'm not going to say, but like, you start talking about doubling your salary, right? And some of those things don't take that much longer, right? There's like 3 years, of GI, and then all of a sudden, you're a GI, and
how much does a MD what do they make?
$500,000 at least. With no experience.
And I just want to say, for veterinarians, cardiology is a subspecialty of internal medicine.
Right.
But to my knowledge, we don't have gastroenterologists.
Yeah.
And I'm a gastroenterologist.
Yeah, well, you don't do endoscopy, so there.
I could, though.
You could.
I could.
You can do anything. That's the amazing thing about
That's right. That's right. I do ophthalmology, cardiology, gastroenterology, surgery.
Critical care,
ER.
At the same time, I was an intern. At the same level of experience that I was an intern, you were running a ICU and surgery center overnight, every night, by yourself.
Yep.
And that was pretty intense, I'm sure. But, we get a lot of extra training. That's another thing.
Yes.
But, the med school thing, and I think the difference, and I'm going to loop back for a second and say, you asked me, well, what's the comparison between med school and vet school. And the difference is, I think, is that we have only 2 years of primary learning, and then we have clinical rotations for 2 years. And that kind of packs it all in. I think by the time I was in clinical learning, in the clinical rotations, I was already kind of done with it. I have to say.
You were done with like sitting in a classroom and. Oh
no, I was done with the whole process. I had decided that, like, that it was so much stuff that by the time that I knew was useless, that I just started looking at the stuff that I thought was useful, and I kind of ignored the rest. And I was just like, well, I wanted to do neurology at that point, and neurology, and it wasn't that competitive, right? And
neurologists don't make great money. In fact.
Well, I mean, they can in private practice, just like everyone else. But the neurologists don't do all that much better than internal medicine, right? But that's part of it is that it's a 4-year versus 3-year. It's only 4 years of neuro. There's 3 years of internal medicine. It's not a subspecialty of medicine. I think it once was, but it's not. But I wanted to do that. It's not that competitive. But then at the very last minute, I switched to internal medicine. I did, one of the things is sometimes, and this is a good lesson for people, I suppose, is that there's something that really fascinates you, right? And you're like, wow, neurology, all this stuff, and the function of the brain, and all these cool syndromes and every nerve, and it's just amazing stuff. And neurology as a subject to study, if you were like a PhD MD or a PhD DVM or whatever, right? You're going to do primary research, is absolutely fascinating, right? And then you go and do neuro rotations, and it's really amazing because you're like figuring all this stuff out and blah, blah, blah. And then, on my 4th neuro rotation, because I did a lot of neuro, I wanted to be real sure. It was more like, all right, so what are we seeing? Seizure, stroke, seizure, stroke, 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 seizure, MS, seizure, 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 stroke, stroke, stroke. And it was like, okay, like, and the funny, and the thing is, like, well, MS is kind of interesting, but there's really only like 6 drugs, right, that you use if you're going to be like an MS specialist, or maybe there's more, but 6 main ones. Stroke specialist. Okay, well, the only decision you make is whether to give TPA or not give TPA, which is like a clot buster, right? And then after that, it's just mainly like, well, I can tell you how much of your brain you're going to lose, but can't do much about it. And seizures is like, okay, well, you give this drug, that didn't work, I'll give this drug. Okay, that didn't work, I'll give this drug. 90% of the time it works the first time. So, and you're only dealing with a very small part of the patient, right? I mean, it's a very important part, but it's a small part. So I decided to be a generalist.
Yeah, just like in 3rd grade, you saw the future and thought, nah.
No, not doing that.
I don't want to do that.
I don't want to do that. And part of it is I didn't want to start a practice, right? It's kind of hard to be an employed neurologist. I mean, there's more of it now than there was then. It's a lot of call without seeing as many patients. And then what
do you mean there's a lot of call without seeing as many patients?
So you have to take call. As a neurologist, you absolutely have to take call.
And by take call, you mean you have your day practice where you see, patients that come in to your clinic and then they go home. But you're also on call for the hospital when they get neuro cases that require a neurologist. That's what you mean?
Exactly. Okay. But there's also, if you just worked for a hospital, they're not going to hire another nocturnal neurologist.
Oh.
Right? You are it for 24 hours at least.
That's insane.
It's
the neurologists that work at your hospital are on call 24.
Not anymore, because we don't have enough of them, so they're splitting things up. one of them does all the hospital call,
Mm-hmm.
and one of them doesn't do any call. But
the one that does all the hospital call, that neurologist isn't on 24/7?
So we don't have 24/7 neurology.
Oh my God.
Because we don't have enough neurologists.
Wow.
So they are on when they're there.
Wow. So what do you do if like a critical neuro patient, I mean, do you like helicopter them down to Phoenix?
We have teleneurology. So if it's nighttime and the neurologist is going to be back in the morning, right? Which works every day except for Saturday because they're not there on Sunday. Then we can consult somebody who uses telemedicine, which is another thing you guys don't have, really. It's telepathology and stuff you have. But to get to the point of it is we can they can be consulted from the ED, put in a plan in place that will last 10 hours.
I see. And
then the neurologist is back in the morning to take over.
Okay.
Basically, the decision is whether to give TPA, not to give TPA, the clot busters for strokes, what seizure drug to give to seizures, and they could give you sort of, if this doesn't work, try that kind of thing. And you can sort of be comfortable if you have a neurologist coming in the next morning.
But if you don't, then they got to go down to Phoenix.
If you don't, they have to go to Phoenix. And, you can't have a telemedicine. The way it works in human medicine is a lot of things are based on what we call standard of care. And I know you have standard of care too, but for us, it's a little different.
Yeah, a lot different.
In that you have to be able to provide things that the patient would need, or else you're negligent in accepting them. So if you accepted a patient who is having, you don't have a neurologist, right? And you're ER, but you could accept a patient who has, status epilepticus. If I'm going to accept a patient in the internal medicine service at my hospital, I have to say, I can provide what that patient needs, or else I shouldn't have accepted them.
You can't accept them into the hospital to be under the care of an internal medicine specialist if they need something you cannot provide.
Right. Like a
neurologist.
Or a neurosurgeon.
Right.
We have a neurosurgeon. Strangely, we have a neurosurgeon on call 24/7, 365, but we don't have a neurologist.
God, that's insane. Like in veterinary medicine, the neurosurgeon is the neurologist.
Yeah. Well, I suppose you could do it that way, but there's so much more to know, and the stakes are higher. Do you really want a surgeon to be prescribing you meds? Come on. I trust them to prescribe antibiotics sometimes.
Oh gosh, this is another funny thing. So your specialists are so far removed sometimes from medicine. It seems like you tell me about they don't want to, like a surgeon not wanting to manage like simple things like diabetes, or a psychiatrist not wanting to manage something simple like, what was it? It was some drug. Was it alcohol withdrawal or diazepam?
Yeah. So, that's kind of funny because that's one of their bread and butter things. They asked me to manage alcohol withdrawal in an alcoholic, and they are like a withdrawal center, but that's neither here nor there. Yeah. That was just one particular person.
Okay.
But they didn't want to manage. They don't want to manage IV medications. They don't want to manage. Surgeons don't want to manage diabetes at all. You commonly get a consult for managing diabetes in someone who's just on oral medications for diabetes at home. It's not like a type 1 diabetic.
Oh my gosh.
So you don't really want to use oral medications in the hospital, but still, really. But on the other hand,
it's such a luxury. Can I just say, for the surgeon to just be able to, I'm just going to think about the surgery. Exactly. I don't want to think about what drugs my patient is on, what comorbidities he has, and
is he going to survive?
How is that going to be affected by being under anesthesia or not eating for 12 hours? I don't want to deal with that. I'm going to call somebody else to manage that part of the patient. I'm just going to do my surgery. That is such an incredible luxury.
On the other hand, for me, it's pretty luxurious when I discover my patient has cholecystitis, that I can just call somebody and say,
oh, yes, yes,
hey,
yes.
This guy,
Absolutely.
he just needs his gallbladder out. Can you take care of that for me? All right, thanks.
Yes, exactly.
And it's done.
Exactly. Versus in a veterinarian.
He has a brain tumor. It needs some radiation. You know how to do that, right? Okay, good. Because I have no idea.
Yeah, exactly. Exactly. So you get to be really good at what you do without having to be really good at all of the other things, because you don't have to do them. That's, but that's the difference.
Urologists focus only on one area,
So on the one hand, you could say that being a veterinarian is much more interesting.
Yeah.
Because I can do, it's up to me. If I don't feel comfortable, depending on where I practice, where, the practice management. But if I feel comfortable with something, I can try it. If I don't, I can ship it. But I don't have to call a gastroenterologist, which doesn't exist. Or,
Plus, you could just read it in a book and try it. That's kind of fun.
Yeah, except for the fact that I actually care about my patients.
Oh, well, come on. You've done surgeries that you've never done, that you've never seen that before.
Because I had to.
Because you had to. Yeah.
Because I had to.
Right.
But that's, you make it sound like, oh yeah, I'll just try it. But it's not like that, because I care about what happens, and it's on me if it goes wrong. And I know that I don't have sufficient training and education. I really shouldn't be doing this, but there's nobody else to do it, and I have to do it. And oh my God. So.
Battlefield medicine.
Yeah.
So, we have that. It's, triage, right? You do what you got to do. But yeah, no, it really sounds incredibly interesting to do, when you were a ED vet, an overnight ED vet, and you were there running being the criticalist and the surgeon and the internal medicine and, the radiologist and all that. Yeah. I was always kind of jealous. I was like, that's so cool.
Yeah. It is cool.
You see a dog and you press on its belly and it's like, oh, okay, well, I don't even know if dogs get cholecystitis, but if they do, you find it right up a quadrant pane or wherever it is on a dog. And, you're like, oh, that dog needs a cholecystectomy, right? I don't know if that's the thing.
That's not how it works, but okay. Yes.
Okay. Right. That's how it works for me.
Yeah.
You press on something. It's not right.
Yeah.
You take a radiograph, you read the radiograph itself, right?
Do an ultrasound,
whatever you can do, whatever you have.
Yeah.
Right. Figure it out. Oh, that's what that part of the patient needs to be somewhere else in the garbage can, for instance. Right. So then you just take them to the OR and you do it. Right?
Yeah.
Do your own intubations, do your own sedation, do everything.
Yes.
Anesthesiologist and surgeon.
Yes.
You do you take care of them post-op, you wake them up, you treat them with the pain meds like the internist would do. Right? Soup to nuts, door to door. Right? You took care of everything on a surgical patient or, a medical and surgical patient. A septic shock from a perforated viscus, right? Soup to nuts, everything. That's the cool part.
Yeah. Yeah, it's very cool.
And I don't get to do that at all. Not at all. The funny thing is when I got my license in Illinois, it said licensed physician and surgeon. And when I saw that, I was like, yeah,
it's like a leftover artifact from, 50 years ago, right?
Yeah.
When it was the same thing.
Well, the surgeons were different, but you could just be a surgeon by learning the surgical technique.
Right. There were surgeons. Wait. How far back are we going to go? Are we going to go back to when surgeons were barbers? No, not that far back.
So when they say licensed physician and surgeon, they mean, I can put a IJ line in, I can, cut an abscess, right? And technically an internist can be trained to do any procedure if you can get someone to train you. So I can learn how to do endoscopy. I can learn how to do surgery, right? No insurance company would ever pay me to do surgery, but because they want board certified surgeons.
And no insurance company would ever cover you to do surgery.
I bet I could find someone who would cover me.
You could get liability insurance to perform surgery. And
but if you were trained on a procedure and signed off on that procedure by somebody who's by a surgeon, and you were going to limit your scope of practice to that procedure, you could get coverage for that procedure.
You know
It'd be
what?
hard.
You know what? Okay, Atul Gawande talks about this book in his book Complications. There's a hernia center. I can't remember where it is, somewhere in the United States, right? And those are surgeons. I mean, they are performing surgery, but they're performing the same surgery again and again and again. And most of those doctors are not, in fact, board certified surgeons.
Yeah, and they don't have to be because they've been signed off on that procedure. If you're a general surgeon, I think you're signed off by default on every procedure, And so,
right. And we've heard how miserable general surgeons' lives are.
Exactly. And if you're a cardiothoracic surgeon, you're not like the general surgeons aren't doing heart surgeries, and I don't think they're signed off on them. Just because they're a surgeon doesn't mean they can do that. Even if you were working in rural Alaska, you still couldn't do it. Now, I think you can do anything if you can argue that the alternative is immediate death and they can't be transported.
Right.
I think I can do anything too. Right. But, that never happens in today's world, right? I suppose if you were in rural Alaska and the closest center was, I was, an internist at an ED, there's no surgeon, right? Mm-hmm. And, my job is to, stabilize and chip, right? Mm-hmm. And somebody came in with a gunshot wound. Well, I could open them up and do whatever I needed, I think. But that doesn't exist in the real world, right? Yeah. I think there's an exemption for you have to do what you have to do.
Here's something that might exist.
At a real hospital, it would never happen.
Okay, here's something that might exist in the real world for MDs.
Yeah.
Let's say you're in rural Alaska and I mean, I don't know what the hospitals are like there, but presumably, or you work at an urgent care center.
Okay.
Let's say, okay, and somebody comes in and they have severe pericardial effusion, and you need to do pericardiocentesis, which is I've talked about this before in previous podcasts, but basically, if there's an inelastic sac around the heart and if that space around the heart fills up with fluid, then the heart cannot expand and therefore it can't pump blood. So this can be life-threatening. So you see now you can have a mild case of pericardial effusion, right? Or you could have a severe case of pericardial effusion.
Yeah, with systemic collapse.
With systemic collapse.
Yeah.
And in that case, even if there's, you could call an ambulance and send that patient to the real hospital.
Yeah.
You can't do that. You have to do pericardiocentesis now, or this patient will die.
Yeah, you should technically be signed off on it, but if you were the only one there, you would just do it. Mm-hmm. And that's one of those things. Like there's a few things that you couldn't work in a hospital in rural Alaska without really knowing how to do at least a hack job of,
Okay.
So I think that it's, I would never try one. I would just I would just call a surgeon. Right. And say, you have to come down here right now.
Right. So a doctor working in rural Alaska, maybe their lives are a little bit similar to veterinarians in that they have to be proficient at more things and knowledgeable about more things than somebody who has the luxury of working in a larger hospital and having all these other specialists to call.
Right. Or just try an ED doctor at a major hospital, right? Mm-hmm. Like you have to be proficient in the first 30 minutes of treatment of almost anything. Mm-hmm, right.
Mm-hmm. Yeah. Right.
So pericardial effusion. Yeah, you have to do it. Mm-hmm. Right. Like, if they're going to go into systemic collapse, gunshot wounds.
Mm-hmm. So the ED doctors at your hospital can do these things?
Yeah, I'm pretty sure they can in an emergency.
Oh, here's another interesting thing.
They also intubate. They also they also put in lines.
Here's another thing that's interesting and different. In veterinary medicine, we have, veterinary assistants, sometimes at some hospitals, or veterinary technicians, maybe not certified, intubating patients.
Yeah.
Right?
Yeah.
But you, as an MD with your 3 years of residency, cannot intubate a patient.
I've done it twice.
Yeah, but when did you do it? You didn't do it unsupervised. In residency, right.
With an anesthesiologist standing there.
Right, with an anesthesiologist standing there.
Why can't I? Well, there's multiple reasons why I can't. First of all, the dog apparently, if you look at where their mouth is, it's on the front. Mm-hmm. The front of the dog. Mm-hmm. Right. So you can it's right in line.
It's a straight shot
in their throat.
The epiglottis.
Bark, 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 zoop, right, straight down, right? Humans are like this. Yeah. You have to go in and then down. Mm-hmm. And it's hard. Mm-hmm. And the second part of it is I'm sure that there's some California entitled idiot or something out there who would like sue a veterinarian for like disturbing their dog's voice.
Oh, right. Mm-hmm.
They're like, oh, my dog is now hoarse. That'll be, $500,000, please, kind of thing. Right. But in human medicine, you have to be real careful. Mm-hmm. Intubating risks injuring the vocal cords, and people's vocal cords are expensive.
Oh gosh, I always thought of it as like it's important to do intubation correctly because you could die, but I didn't think about like the more subtle things that could go wrong, like you could
injure a vocal cord
and then get sued for $500,000. Holy crap! Yeah. Okay, so there was something else that I wanted to ask you, but it was okay. This is all very fascinating, but I didn't mean to skip over the part about medical school where you don't have to go to class.
Oh, and the thing about it is you could learn so much more quickly if you weren't there.
Exactly, so true. Just read a textbook.
Yes.
The
only thing you went to class for was for the notes. You could get notes or recordings of any class you wanted.
As a favor from other students.
Yeah.
Okay, yeah. I mean, we did that too, but we had to be there.
Yeah. So basically we didn't, and most people didn't go. So.
Okay, what a luxury. What an incredible luxury.
But
I think I would have learned a lot more if I hadn't had to have gone to every lecture.
Yeah, I mean, if you can argue that I could have learned more by reading, not having gone to the first 2 years of med school at all.
Just give me a reading list.
And then just had like, anatomy lab and my second 2 years after I read and memorized, 40 books.
Right.
Like I could have done a better job. There would have been less commuting.
Mm-hmm. Yeah, but I mean, to have that luxury, I just, because it's so exhausting, Monday through Friday, all day long, and then studying at night. Like
you're trying to study for an exam and you have to go to a class, right?
Yeah. I mean, just to have the luxury of saying, I'm pushing myself too hard. I am exhausted. I'm not going to school today.
Yeah.
Would have made a huge difference.
Yeah. Well, we didn't. I don't think any place really has mandatory classes, although I'm sure like everything, it's all, it's all, per school, but I hadn't heard of anyone who had mandatory classes.
No, it seems like it's pretty prevalent that
Yeah.
you don't in medical school, and yet in veterinary school.
Yeah. The problem is you are expected to know enough at the end of it to practice, right?
Me.
Yeah. Mm-hmm. Right. Well, veterinarians are expected to know enough at the end of it to practice. Mm-hmm. That's hard. I mean, you have to really know that stuff. And even then you don't have that much clinical experience. So you're really not applying it well.
No.
Right. I mean, when I'm done with med school, I get a full 2 years in med of clinicals, which is just like apprenticeship without working. And then you have at least 3 years of residency. Which is clinical, which is an apprenticeship with working. Mm-hmm. And so by the time you're walking out onto your first floor post residency, you've
as a real doctor
technically have 5 years of clinical experience.
Exactly.
But even that they're like dog years or something. I think I've learned it. Like 1/7 or something, the years you do before you're actually out there.
Uh-huh.
I don't know. But basically, I think that my 5 years of clinical experience were worth about 1.5 of really being a real doctor.
Yeah.
But that's good enough.
But it's still better than being in the classroom.
Start. It's a good start. Yeah. Mm-hmm. So then we have a lot more experience when we start. And that's, I guess good and bad. We have to spend 3 years working for, slave wages even after med school.
You call it slave wages, but what you were making during your residency is twice what a veterinary intern would make.
Yeah. How do they get around the minimum wage laws then?
Well, because those don't apply, and neither do like strict limits on working hours or bathroom breaks or lunch breaks. That only applies if you're not a professional. If you're a professional, there's nothing that's regulating how your employer treats you. Did you know that?
Well, you still have to get minimum wage, I think.
No. Who's going to say that's like, okay, well, it depends. Who's going to do the math? Like some I don't know, regulator is going to be like, oh, okay, so you make $26,000 as a veterinary intern, but you work 100 hours a week. Mm-hmm. You know, is somebody, I don't know, who's watching and saying, hey, that's less than minimum wage. No, nobody's watching.
Somebody's job it is to watch, but no, I guess nobody's complained.
No. My understanding is, and even like I remember when I was working in advertising, and I was working a lot of hours, mm-hmm. and I think I looked into it because I was like, this is ridiculous. I've been up for 20 hours straight, and like, aren't I supposed to have a break or something like that? No, if you're a professional, no, you get a salary, and that's what you get.
But anyway, I think that it was still 3 years that I wasn't, at my full salary.
Oh yeah, for sure.
So, I think that in the end you have to decide how much you want to enjoy those 3 years. Residency is tough. Mm-hmm. It's tough. Mm-hmm. You get the tough blocks, and you're, working 16 hours a day for 28 out of 31 days. Mm-hmm. Then that's not easy to do. Yeah. Breaks you down a little bit. Yeah. But, I think I had a less horrible residency experience than a lot of people did, because I kind of went to a community hospital for residency. I didn't want to go to so basically the life story continues of, I decide I want to do internal medicine, and then I decide that I don't ever want to have a clinic. Yes, right, exactly. So basically I'm a hospitalist, right?
Yeah.
So hospital medicine only.
Yeah.
Once you leave the hospital, you're not my problem.
Yeah. And I think this is another thing that we need to explain a little bit more to people out there who don't understand the intricacies of outpatient, inpatient, hospital, clinic, blah, blah, blah.
So as I'm going through residency, I've decided this already. So I don't really have to be
yes, but hold on.
A superstar.
Yeah, but we haven't explained that part. Are you going to? I'll explain it. Okay, so when he says he knew he didn't want to be in clinics, right? You didn't want to be a quote unquote clinician. Mm-hmm. That means outpatient medicine.
Yeah.
Okay, so outpatient medicine is doctor's office, and it could be a GP, it could be a family medicine doctor. Internal medicine doctors have clinics where you walk in. You don't need to be hospitalized. They give you a prescription, and you walk out and you go home.
I think it's a pretty easy concept there. Like when you go to the doctor, it's a clinic.
Right. But but a lot of people don't understand this. Hospitalist, inpatient, outpatient. And I didn't understand it until I started practicing. Mm-hmm. And especially like when you and I met, and like you told me about these these subtle differences in human medicine. So inpatient is hospital medicine, and a lot of people might not even, I talk to people all the time who don't know what a hospitalist is. And there's no such thing as a hospitalist in veterinary medicine, as far as I know. I mean, that would just be an ER vet or a criticalist. Mm-hmm. So Alex, my husband, Mr. MD, does not want to do outpatient medicine.
Correct.
Is what we're talking about. Sorry if I over-explained, but I don't think I did.
What?
Go on.
With what? I can't remember what I was talking about. So what was I talking about?
You were talking about, you decided in residency that you did not want to do clinic medicine.
Yeah. So clinical medicine is horrible, in my opinion, which is why I don't do it. Mm-hmm. There's clinicians out there who do clinic medicine and they like it. Mm-hmm. I don't know any. But
can you tell us why?
Why? Yes, why is clinic terrible? Okay. So everybody out there, no. Why is clinic terrible? Clinic is terrible because you're dealing with chronic problems with non-compliant patients.
Mm-hmm.
So, or you're dealing with easy, trivial stuff that should be really handled by, over-the-counter drugs, right? So either people are coming in with a cold
Mm-hmm.
and thinking that they need antibiotics, and then you have the, 150,000th reading of the "you don't need antibiotics for a cold" speech,
Mm-hmm.
or they're coming in for actual pneumonia, in which case you just give them some antibiotics, or you can't get things done quickly. Like, can you get an X-ray and read it and treat them?
See, in veterinary general practice, you could.
You can. And we had that. Some clinics have X-ray and some clinics have, but you can't get blood tests back all that quickly.
In veterinary medicine, you do your own blood work.
Yeah.
In-house. Most of them, not all of them.
And some of the
I
bigger
personally
clinics,
wouldn't work at a clinic where you couldn't do in-house
basic blood work.
Blood work, yeah.
And some of the places do have basic blood work, and you can do that too. But then that just says, okay, well, now how much time are you going to spend on your, 15, 20-minute appointment? Really, you're just going to send them for blood work and treat them when they come back,
Mm-hmm.
right? Or you're going to walk in, listen to their lungs, say, you have pneumonia, go get an X-ray and come back.
Mm-hmm.
Okay, fine. And then you treat them with, cookbook coverage for community-acquired pneumonia,
Mm-hmm.
right? So, or, they were in the hospital recently, so you have to treat them for hospital-acquired pneumonia,
Mm-hmm.
right? But it's really, and there's too much in the way of relationships that you have to build with these people so they actually listen to you, and why, like.
So that they listen to you or so that they like you? Because there's
a certain amount
HCAP
of
scores, which is like measures of patient satisfaction that you MDs didn't used to have to worry about, and now you do.
Yeah, there's that. But I think that's like the smallest part of why clinic sucks. So
okay.
the rest of why clinic sucks is that, what are you seeing? 30-year-olds with no medical problems go to the doctor every
year. Maybe.
Not even 5 years, 3 years, something like that, right? Who comes all the time? People who come all the time are, heart failure patients, multiple comorbidities, diabetics, right? All this stuff, right?
Yeah.
And I don't have anything against diabetics. I mean, whatever. But like, they're terrible to treat.
What if it was my father, the diabetic?
Yeah, your father, the diabetic, is the perfect clinic patient. He was obstinate and non-compliant and had all of his complications from that. Mm-hmm. And, eventually he basically offed himself with non-compliance with medical treatment, and, could have done so multiple other times. Yeah. And you're like, well, he was a nice guy, but, on the other hand, like, really, what am I doing here? Right.
Mm-hmm. Yes.
And it's even worse if you like them.
Right.
Right. If you like a patient, I mean, he was kind of a easy non-compliant patient, right?
My father was easy?
As non-compliance patients go, easy for the doctor to deal with, which is, you're non-compliant, you're never going to be compliant. You're also obstinate and argumentative, and I hate you.
Oh, so it's easy because you don't care about them, right? Because you're a jerk. He made the decision.
He made the call, and that's different for you guys because the patient doesn't make the call.
Yeah.
But, for us, a non-compliant patient that you really dislike is not that bad.
Right.
A non-compliant, sweet, nice, happy, 75-year-old, 75, you're pretty much,
mm-hmm.
I shouldn't really say, but you're pretty much done, right? Mm-hmm. Like, you're either healthy or you're not healthy, and you can start smoking at that point for all I care, right? So, you're going to get a heart attack a little sooner, but okay. So a 50-year-old guy who's morbidly obese and diabetic and won't control his diabetes and won't lose weight, mm-hmm. and has heart disease and then comes in and complains about his peripheral neuropathy, mm-hmm. right? Like burning sensations in the legs, mm-hmm. which is from diabetes, yes. from not controlling your sugars, yes. right?
Yes.
And, and then you go through drug A, drug B, drug C, drug D, right?
Yeah.
And nothing works, and they're frustrated, and you're frustrated because they're a nice guy, and you want to help them,
but you can't.
And you can't, and blah blah blah.
Yeah,
right. And everybody wants opioids, So then you get to the point where you say, well, what if I just took care of patients for a problem that they had, and then I treated that problem as much as I could, and then I never had to see him again, right? Like, and that's a hospitalist, right? You come into the hospital not because I'm going to manage your heart condition for the next 20 years. It's because
and your 7 different medications,
making sure that you're, not having any side effects from your long-term seizure meds, that are interfering with your quality of life, right?
Yes.
No, I mean, I can catch those things, right? But that's not my job.
Right.
My job is, you came in with a heart attack, right? Well, a heart attack's bad. You come in with pneumonia, right? I diagnose you with pneumonia with radiology. I treat you for pneumonia, right? I try to prevent you from going into septic shock. If you go into septic shock, I treat that too. Guess what? You're all better. You don't have pneumonia anymore. Okay? Bye. I'll never see you again. And I always tell my patients when they're leaving the hospital is like, I really hope I never see you again. It's like the only time I want to see you is in a grocery store.
Right.
Because otherwise I meant you came back to the hospital, and nobody wants to be in the hospital, right? Yeah. Like, I'll see you for some elective surgery in 5 years. But other than that, just stay the heck out.
Yeah.
And that's part of it. And that's why I don't like clinic medicine.
Yeah.
Well, and then there's the day of clinic medicine, which is you always have just enough time to see a patient if they're simple. Right?
Yes, exactly. And this is the same thing in veterinary medicine.
Oh yeah. And I remember you complaining about it.
Yeah.
You just have enough time to see the patient if it's
simple.
If it's exactly what they came in for, and it's straightforward, and you don't need anything else.
Yes.
That's how much time you have.
Rarely the case.
Right.
In human or veterinary medicine.
Right. So then you get behind.
Yeah.
And you're always worried that the people are upset that you're behind. You're always trying to catch back up. You're hoping somebody cancels, right? So you can actually catch back up, space, right?
Yeah.
And, and if you need to work on somebody for 2 hours, you just can't. That's it. You can't. Right. So you send them to a hospital, right? Which means that basically you end up only working on simple cases.
Yeah.
Or chronic cases.
Which is like boring and laborious.
And then most of the really interesting chronic cases you shuttle off to a specialist.
Yeah.
So now you're a specialist, you're working in clinic, right? You see the same 5 cases all day, right? You're an endocrinologist, you see thyroid, you see, diabetes and thyroid, right?
Yeah,
that's it.
That's it.
Like, every,
this is what you were talking about before with neurology, like, oh, it's so interesting. However, reality.
Exactly. Parathyroid, right?
Yeah.
And then, beyond that, like, who's, all the really cool stuff you learned about in endocrinology, like gastrin leptin system and this and that and the other thing. And like, is like a sideline of a sideline. And usually you end up sending them to like a subspecialist, right? Because you don't have the capacity. If you're a cardiologist, you see coronary artery disease, you see heart failure, you see alcoholic cardiomyopathy, you see like 5 things, right? All day, every day, right? And, and that's this curse of being a specialist too, right? Is that being a specialist limits you as much as it specializes you, right? So, and I think that even what I was getting at though is even in a specialty clinic, you don't do the cool stuff, right? Yeah. Most of that stuff's done in hospital, right? And the clinic life is a life of not having all of the resources that you need to definitively treat real cases while constantly being barraged by fake cases and non-compliant patients. So you end up in that situation, and that's the clinical life. I mean, it really is. I'm sure it's the same in dog meds too, and cat meds. Meds.
I think a veterinary general practice general practitioner has a little bit more satisfaction because we do the radiology, we do the blood work. So we have.
And you sometimes do surgery.
Yes. I mean, well, general practice, they actually do a lot of surgery, elective surgeries,
right?
Like spays, neuters, dentals,
Mm-hmm.
maybe like a large lipoma removal, something like that. And some of them will do emergency surgeries too, gastric foreign bodies.
Sure.
But so general practitioners that are veterinarians are going to have more stimulation, more intellectual stimulation, more variety to their day. So that's one of the good things. But the bad thing is, okay, MDs, 15-minute appointments, and they get behind, right? But you guys aren't doing radiographs and you aren't doing blood work. And if you did blood work, all you'd have to say is, could you please hold out your arm and hold still while I draw a blood sample? Whereas we have to wrestle our patients to get the blood sample, right? Or
human doctors don't do blood work.
Exactly. I mean they don't do venipuncture.
Somebody else does that.
Exactly. Yeah. Yes. But what I'm saying is, so you guys have it's impossible even for MD GPs to keep up with their schedule, and they've got 15-minute appointment all day long.
Yeah.
Right. But they aren't doing procedures. They aren't.
Yeah. No,
so
it's easier.
That's easier. Yeah, but you still end up behind. So imagine from a veterinarian's point of view, if you've got 15-minute appointments, it's great. We do the radiographs, we do the blood work. Maybe we can fix what's wrong. It's more interesting. There's more variety. But at the same time, how can you? It's like impossible sometimes.
Yeah, well, I'm sure it is. And, and I think 15-minute appointments for human docs is not the standard yet. I think it's 20s, which is a little better. Mm-hmm. But you're talking about multi-systems. That's the problem. Is like dogs generally have, and cats generally have one thing wrong with them, right? You're not managing 8 chronic medications, right? You're not managing multiple problems. Oh, and also I have peripheral neuropathy and my drugs aren't working.
Yeah.
Oh, and also my legs are swelling a little bit because my Lasix dose is a little too low. Mm-hmm. Oh, and also, my asthma medication is not,
right.
really holding.
That's true. That's true. Okay. So you got me on that. Maybe it's equivalence.
I think we need a little more time too, because they talk and I know your clients talk, but you can't really say, what you're saying is unrelated to reality.
Well, no, you can't say that. And I can't say that, even though it's true in many cases.
No, you can't say that. I can. I tell people all the time. I'm like, no,
you do?
Yeah.
Well, that's because you're a hospitalist and you don't have to have patients that like
even in clinic, I'm like, no, that's not related. No. But, and they do have to like me. I'm supposed to maintain an 85% positive review.
Right.
So I can get a trivial bonus.
Right.
But, the thing about the clinics is, not so much that you're busy, is that you're busy with mundane bullshit. To be honest, like how many times can you do that? And then you're busy with people who are not going to do, even like, let's take you. You're the ideal. Okay, you're a terrible patient. You're the ideal patient for an internal medicine practice, which is you go in,
yes.
You're on like 1 or 2 little things, right?
Yeah.
And you're totally compliant, right?
Because I know,
right?
I know the consequences of not being.
And this
compliant.
is my point. You're totally compliant. You're willing to make changes. You're this and that, right? So you're ideal patient, right? From that perspective, and yet it would be boring beyond words to have like a whole day worth of you. My wife basically goes to the poor clinic because I won't say which one, but basically it's where we send the people with like terrible insurance. And the reason is because when we first moved here, you just needed an appointment and they were the ones who would say, yep,
yes,
you can have an appointment right now.
That's right.
And so you ended up going to
no, can't see you.
Exactly. No, we can't see you. It'll take 2 months, blah, blah, blah. Oh. But you ended up at that place because, and what you ended up with was like, you ended up with a really good doctor because
he's awesome.
He's med peds, he's dual residency trained. He's like,
yes,
he's a good guy. I happen to know he's a good guy.
Yeah.
but you could have ended up with not so great there.
Well, but the
15-minute appointments is because you go to that clinic.
I see.
So you're in that situation. That's another thing too, is that you have to worry about whether your patients are the right patient mix if you're going to be as happy in a clinic as a human doctor, right? Like, I suppose you have to worry about where you practice too.
Yes.
Do the people have money?
Right.
Where we are is like, do the people have insurance? And do they have good insurance?
Yeah.
Because if you're seeing all Medicaid patients, right, Medicaid doesn't even pay for the wallpaper on the exam room, if you ever get paid at all. And this is what people don't understand about like why they get these huge bills in the mail, right? If they're insured, right, and your insurance company ends up paying whatever percentage of it they pay, right? Well, and they say, well, why can't we have Medicare for everyone, right? Medicare. If every patient had only Medicare insurance and no supplemental insurance, and there were no private pay patients and there were no private insurance patients, like, it's literally half. Right. So every hospital in the United States would close. Yes, exactly. Or you would just have to treat people terribly.
Exactly.
Right.
So stop for a moment, because there's some really interesting stuff that I don't want to forget to mention. So one of them is non-compliant patients. I think for veterinarians, for future veterinarians, it may be liberating for you to know, because a lot of times veterinarians, we get very frustrated with clients who come in with pets, and we love the pets and we want to help the pets, and the clients won't follow our directions, right? And it upsets us. And we feel like, oh, they're terrible. They don't care about they don't care about their dog or cat. But the reality is, it's not that they don't care about their dog or cat, because they're not compliant when they go to their own doctor.
Yeah, people are lazy.
They just don't. Lazy, whatever. Don't understand, too busy, whatever.
No, they're just lazy.
Yeah, and it's not that they don't care about their dog or cat. Like, they don't follow their directions, their doctor's directions either. So don't get upset with them. That's just how they are.
Yeah,
that was one thing I wanted to mention.
Yeah, and as much as they don't have time for themselves, sometimes they have time for their animals, but I've seen people who take much better care of their animals than they do themselves.
There's that as well. I'm just saying, talking to you about patients that are non-compliant has been revelatory for me. I just thought,
people would take their medicine?
I just thought that they were non-compliant because they didn't care about their dog or their cat, which broke my heart. But now I know that they're non-compliant for their own medical issues too.
Oh, yeah.
And,
and especially the ones that are seen a lot, right?
Yeah.
If you're compliant with your diabetes control, and you're one of these people who, got diabetes not because they were morbidly obese, or they were, but then they lost weight, they lost weight. And you say, okay, well, I'm going to be on it. I'm going to check 3 times a day, every day. I'm going to adjust my insulin. I'm going to go to the doctor. I'm going to get my A1C checked. I'm going to adjust my insulin. I'm going to keep my blood sugar in control, blah, 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 blah. Right? Perfect, right? The perfect patient. I'm going to exercise. I'm not going to drink soda. I'm going to follow the diabetic eating plan. It's a big deal being a real diabetic.
Oh yeah. Much better just to not get it.
Yeah, exactly. In the first place.
That's why you need to be compliant, so you don't get diabetes, because it's impossible to be a compliant diabetic.
So even if you do all that stuff, then you're not seen, right? You're there twice a year, right? For 15 minutes for an A1C check. Oh, it's doing fine. You think you're doing okay with your insulin. Yeah. Okay, good. Perfect. Next patient. Well, that's kind of a boring case, right? The other side of it is the patient who isn't compliant and they have every diabetic complication. It destroys your eyes. It destroys your feet. It destroys your skin. It destroys your nerves. It destroys your heart. It destroys
your kidneys.
Your kidneys is a big one.
Your brain.
You can actually get some dementia from it. It's not that big of a deal, but
that would be a secondary complication of vasculopathy, microstrokes,
vasculopathy, all that. Yeah. Basically, you'll die. So
slowly,
much,
and one tiny piece at a time,
and in unpleasant ways, and much slower than much faster than you would otherwise, but not fast enough. So it's not like somebody who's non-compliant with antibiotics and rots their lungs out and goes into sepsis and dies at home,
Mm-hmm.
right?
Right. Yes.
They do that over a 25-year period.
Mm-hmm.
So those are the people who come to clinic.
Mm-hmm.
Right?
Understand. So I just wanted to tell people, like future veterinarians, about like non-compliant clients, like, don't get upset and like, because people, it's not just that they don't care about their dogs or cats. Like people aren't compliant with their own medical issues. That was the first point.
Sure. And they don't clean their bathtub and they,
Right. The second point I wanted to make, just before we forget, because we're doing a comparison here.
Yeah. Oh, right.
The second point is when you talked about the reason I was able to get into, what did you call it? The poor clinic or something?
Oh, it's really a clinic for anybody. It's not a poor clinic.
But mostly it's people who don't have very good insurance.
Yeah.
Right. And so they need to see as many patients as possible in order to make enough money to stay open.
Right.
Which is why when they're like all the other doctors in the area were like, oh, we can't see you for 2 months.
Yeah.
And so they were like, oh yeah, we can see you, today.
Yeah.
And it's the same thing that happens in veterinary medicine.
Did they say that before or after you told them what insurance you have? But I think it was probably even before. They just need to see people. Yeah.
Yeah.
They just need to see people.
I don't know. I can't remember.
Because you have really good insurance. So they're exceptionally happy to have you there. You're paying for like 2 other people.
Jeez.
But
yeah. So, but the same thing, it's the same thing in veterinary medicine. Like there are some clinics that, they charge more so that they can see fewer patients, so they can practice a higher standard of care.
Yeah.
And those are the clinics where, maybe they're not going to just fit everybody in. And then there are the clinics that do fit everybody in. Yeah. And
yeah, there was that terrible one you worked for. But that's won't mention which one.
No.
But it was terrible. But basically we have the situation where if you can get an old school GP, right? Mm-hmm. We'll take, half an hour on a case. Mm-hmm. They're not making as much as they could. Mm-hmm. They're not, they're only taking patients that they know they can spend that much time on and still pay the bills. Mm-hmm. Right.
And maybe they graduated from medical school 40 years ago and don't have any student loan debt. So they don't need to make as much.
Well, they can be more happy that way. Yeah. Mm-hmm. And, so then you have the flip side of it, which is hospital medicine, and hospital medicine is just self-directed. See the sickest patients first, do whatever you need to do, come back to them later. They're still there. They're in the bed.
Mm-hmm. Yes. Right? Yes. It's just like veterinary ER.
Figuring out the workup, stash them for a while, come back to them, and it's much easier. So I think anybody who's thinking about, anybody who thinks that what I'm talking about sounds good is more of like, in your world, it would be more like a surgeon, right? Like you have, you're a consultant, you do the cases as they come, right? You have your surgery schedule, but you set it up, right? You for the elective procedures, right? If you are too long on one, then the next one waits, right? And you can practice the standard of medicine that you want to practice as in that sphere. You're fixing an issue. You're not doing chronic medicine, chronic care of non-compliant patients. You're fixing an issue. You're pushing it. You turn over care back to the GP.
Why not say that's analogous to an ER vet?
Yeah, an ER vet too. Yeah,
because I would argue that it's not really that analogous to a veterinary surgeon, because veterinary surgeons, some of them are on call for ERs, and then they come in and they do the GDV surgery or the gastric foreign body or whatever. But a lot of them they're clinicians. They do clinic medicine. They see consultations sent to them from a GP. This dog needs a knee surgery. This dog needs a hip surgery.
Sure.
And they do a lot of the same surgeries over and over again.
Yeah, but you're dealing with, in that case, one issue that you're asked to correct, and then you correct it and you send it back. No chronic care medicine. No.
Right.
I think you're right, though, that the most like the hospitalist job is the ED, is a ER doc for you guys.
Yeah.
Is that's it's a little bit of a hybrid, though, because people are bringing in things that I don't see patients unless it's already been decided they need to be hospitalized. You're seeing a lot of things that are basically clinic stuff, and then some things that are emergency stuff.
Right. Yeah.
Right. And it's partly just because like it's 5 p.m. and the vets aren't open anymore. Right. So you're seeing my dog's barfing. Well, your dog's barfing because it ate whatever
dietary indiscretion, right? Or my dog has an ear infection.
Right. Exactly.
Yeah. Yeah.
But I think that's the most like it in terms of one issue, 1 to 2 issues, turn it around, send it out, write a letter saying, you should see your general practitioner. And then be like, every time I write that, I feel like this warmth inside that it's not me.
That's how I felt when I was an ear vet.
Yeah. You should follow up with your regular doctor who isn't me. And come back if, your leg falls off.
Yeah. Yeah. Because it's not that interesting and it's not that satisfying. And the stuff that needs to be seen over and over again is stuff that needs to be managed and can't be fixed or cured.
Right.
Like diabetes. Like
exactly. I mean, if you
it's not satisfying.
If you could fix it, then it would be
awesome.
Yeah.
It would be very satisfying. But yeah, I mean, a lot of chronic stuff. I mean, that's why it's chronic, because you can't fix it.
We'll give you an artificial pancreas. It's all good.
Right. Someday, not in our lifetimes, I think. But yeah, so that's why you should be very, very careful never to get diabetes. It's a preventable disease.
Yeah.
Terrible. Just don't go there because you think it's hard to control your weight and your diet before you get diabetes. I'm
pre-diabetic. Okay, what are you doing about it?
Exactly.
Then welcome to a lifetime of a world of hurt.
Right, exactly.
But that's just people. People will do everything.
Part of the reason why I am compliant is not only because of what I saw my dad go through, but because I understand the medicine. I understand how it works, why it works. And I'm just not like, looking on the internet for answers that don't make any medical sense. But,
well, you got to start taking a tablespoon of cinnamon every day. What is it? Is it cinnamon? No, now it's like nutmeg, something.
In the veterinary world, it's coconut oil. It's the cure-all for everything. Turmeric, maybe?
Turmeric.
Turmeric is another one. Now, turmeric does, in fact, have
now
some genuine anti-inflammatory properties.
Yeah, so does Advil. And
so the same thing's happening. This is another really interesting, similarities and differences, right? Veterinarians get very frustrated when our clients come in and they want to argue us about the poison that we're pushing in our vaccines, the poisons that we're using in our heartworm preventative medications, the poison that we're using in our flea preventative medications that actually do work. And they want to tell us why coconut oil is going to work instead.
Okay.
We get upset. It
you get upset.
Us.
You get upset, I think, because they're not doing it to themselves.
Yes, but
somebody comes in and they're like, "I want to use turmeric instead of antibiotics." I'd be like, "You go right ahead and do that, and I'll see you in a couple days." I'll fix you then too. I can fix you now. I can fix you later. Just do what you need to do. But
it's something that MDs have to deal with as well. People are people, and when they come in the veterinary clinic, they've got ideas about coconut oil and whatever the new fad is.
Turmeric.
Turmeric, and when they go to MDs, they have the same. They're talking about the same things. Yeah, and there's videos on the internet, about lemon juice curing cancer and all that kind of stuff. So, you guys deal with the same stuff that we have to deal with. And sometimes I think veterinarians forget, it insults us. Why are you here? If you just are going to believe whatever you read on the internet, go then. I have all this knowledge, and you're telling me about coconut oil.
Yeah.
But it's don't take it personally because it happens to MDs too. And it's not that they disrespect the veterinarian.
It's harder for you though.
It's harder for us.
Yeah. Well, because the patient isn't the client.
Yes.
The patient's not making the decision.
That's the fundamental difficulty, I think.
Yeah. For us, the patient is making the decision. Okay, fine.
Yeah, you're not going to feel guilty about it.
A patient can go and, drive his car 190 miles an hour on the freeway and drive into a bridge abutment too. I mean, like, really at the end of the day, is it my problem? No, it's my role is to educate as well as I can, offer the best treatment available. They don't want to take it. Well, I'll see you in like 5 years for your foot removal. Like, okay, it's fine with me.
He's talking about diabetics.
Yeah. Like, we have diabetics who start to, have a little bit of skin problems and they come into the hospital for something else because they have like heart disease or something like that. And we're like, your A1C is twice normal. I don't know how attached you are to your feet, but you're not going to be attached to your feet for more than another 5-6 years,
Yeah.
Like, and I'll put it like that. It's like, you want to keep your feet for the rest of your life.
Yeah.
So
this is a difference in veterinary medicine is dogs and cats with diabetes don't live long enough to develop the chronic complications of human diabetics, like the vasculopathies, the neuropathies.
You just have to keep it under enough control so they don't die of it, right?
Right. So they don't become hypoglycemic or hyperglycemic. Go into DKA. Right. So we have a much wider margin of error for controlling pet diabetics.
You don't end up with, you don't take care of yourself now, and in 20 years, this is going to happen to you. You don't put dogs on statins, do you?
No, but we do put them on blood pressure medication. We do manage heart disease. Yeah. So there are some chronic issues that we do manage.
What I'm trying to get at is, are you managing it so that they don't die from it? Or are you managing it so that 20 years from now, their hypertension didn't make them have cardiomyopathy?
I see.
Right? Like, you have to worry about in humans, like, what is this going to do to them in 20 years?
Right.
They don't really have chronic complications in the same way that I've ever heard of. Right. You've never told me about it.
Right. Simply because they don't live as long.
Right. I mean, a human can be hypertensive for 30, 40 years before they have hypertensive heart failure. Right. Well, I mean, you get an 8-year-old hypertensive dog, you just have to make sure they don't, have a brain aneurysm, right? Like, you're treating it for that, right? You're treating the condition. You're like humans. And this is a thing that's completely different from humans in veterinary medicine. This is actually really interesting. I spend if I was in clinic, right, I would spend almost all of my time treating risk versus treating patients, right? So what do I mean by that? Treating risk is not the same as treating disease.
So people with high cholesterol, but no signs of vascular disease.
Right. May never, ever benefit from the treatment for cholesterol. They could run into a bridge in 20 years. They could be one of those lucky people who never gets coronary artery disease. Like, people live to 100 in the 1800s, right? Like, every once in a while, right?
Yeah.
And if you make it to 30 with no childhood diseases, your chances of making it to 85 are great, right? So, really, what am I doing? Am I giving you a statin to treat your cholesterol? No. I'm giving you a statin to reduce the risk from, 40% to 15%, that between the age of 65 and 75, you're going to have a huge MI. But you have to take it.
Infarction.
Yeah, you have to take it for 25 years to get any benefit. I mean, there's a lot of studies now that it benefits you more. It benefits you at a lower level sooner. But like high blood pressure, my grandma had high blood pressure until she died at the age of 99. Never ever controlled, right? Well, why do I treat blood pressure at all? I mean, because a certain percentage of people will develop hypertensive cardiomyopathy, heart failure from
20 years from now,
blood pressure 30 years out.
Yeah.
And why do I treat diabetes aggressively? Like, you can go through life with a blood sugar of 330 and you'll just urinate a little more, right? 10 years out, you'll have some complication. 15 years out, you'll have some complication, and 20 years out, you're going to have serious complications, And so, for the most part, I end up treating risk of future illness in the outpatient setting.
Mm-hmm.
I mean, really, that's all there is.
Yeah.
People with like high thyroid levels feel fine for the most part, unless they're super high. People with, cancer screenings is to prevent, reduce risk of cancer. Mammography is to reduce risk of breast cancer, although it may or may not do anything.
Not to reduce risk of breast cancer, but to
reduce risk of metastatic breast cancer. Yeah. And, like dietary recommendations are all just risk reduction.
That's right.
Right? How many people do you actually treat for something?
Right.
Right? Well, the simple cases, the people who come in with a cold and you say no antibiotics, the people who come in with pneumonia and you give them antibiotics, sinus infection, blah, 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 super high thyroid. That's kind of interesting. But really, it's mostly treatment of risk. And all the studies that are being done now in human medicine are almost all the big seminal studies are risk factor studies. It's does this reduce the risk of X more by enough to justify the side effects of whatever you're doing? And that's always the question now. It's not, does vancomycin cure bacterial pneumonia?
Right.
It's not, it's like, is it worth it to give somebody a statin at age 30 and expose them to an extra decade? Or is it better to start at 40 because, they're not, what's the risk of taking a statin for 10 years and how much does it cost?
Right. So this is an interesting segue into the topic of evidence-based medicine.
Yeah.
Can you give a summary of evidence-based medicine?
So evidence-based medicine, to me, and everybody has a different way of looking at this, is that as a baseline, if you don't have a reason not to do something, there are certain things that you have to do on everyone in a certain class. So if you're a diabetic, right, the evidence points to risk reduction in complications of diabetes if you keep your hemoglobin A1C level, which is just, you don't even have to know what that is. It's just a number under 6, right? And then you say, okay, well, why a 6? Well, because the study says 6. And well, why did the study say 6? Well, if you try to make it 5.5, you get more people who have low blood sugar, they crash their cars, they feel terrible, whatever it is, right? It's hard to do without making them too low, right, on sugar. Hypothetically, it protects their kidneys a little better, but it doesn't outweigh the risks on the other side or the harms on the other side.
Right.
You say, well, if you're 40 and you have diabetes, you should be on a statin medication. Well, why? Why if you didn't have diabetes? Well, because it puts you at a high enough risk of having a heart attack when you have high cholesterol and diabetes that it's worth the money and the side effects of the statin. How do they know?
I'm bored. Are you bored? But this is the point.
And how do you know?
Yeah.
Well, because they did a study of 30,000 people.
Right.
And they found a 1% difference.
Exactly. Yeah. So this is, okay, similarities, differences, right?
Yeah.
Evidence-based medicine, not really a thing in veterinary medicine. I mean, we would like it to be on the one hand, because, part of the thing that gives a lot of veterinarians anxiety is there's a lot of conditions for which we're not 100% sure what the best thing is to do.
Yeah.
In every case. Whereas you guys have a lot more direction in that. Okay. So that can cause some anxiety for us. But the other thing is, okay, you have a study where there's 30,000, N equals 30,000.
Yeah.
Right. The bigger the number, the more the more reliable the data is in general.
Yeah. And the bigger the number, the more nitpicky you can get about things.
Yes, exactly. We have studies in veterinary medicine where it's like N equals 7. N equals, N equals 48. And you're like, oh, 48.
Yeah. And if you say N equals 48 and you say, do statins prevent a heart attack? And you say, well, yeah. Okay. So then everybody should be on a statin starting at age 0. right? Until they die, right? And that's about as good as you can do with n equals 48, right? So you can't really
I don't even think you could say that everybody should be on a statin from age 0 if n equals 48.
Well, you probably could if it made a big difference.
It made a big difference. But so the point is, this is one reason why evidence-based medicine is so well established in human medicine, because you guys actually have evidence.
Yeah, and then there's the size of the samples lets you get down into micromanaging things. Exactly.
Yeah. And that's where the boring part is. So for us, it's like anxiety, like, I was 10 different veterinarians and they said 10 different things. Versus in your world, no, it's very clear exactly what you should be doing, because, this is class 1 evidence-based, this is class 2, different. Do you want to explain the different classes?
Not really, because I don't remember them all. Class 1 evidence is the kind that we have most of the time for most major recommendations.
Yeah.
And that is multiple large randomized control trials have shown a clear benefit to this.
Yeah. So class 1, higher confidence level.
Yeah. So then you say, okay, well, class 1 evidence would be like, you should have your A1C checked in diabetes and control your blood sugar.
Right? Yeah, right. Yeah.
And, statins are good for people who have had a heart attack to prevent a second one. It's absolutely clear that is true. Right. Well, then you get down to the edges and you say, well, what age? Right. Well, it's very hard to tell you have to have a very long-term study of a very large number of people to say that you should start at 35 or you should start at 40 years old. And that's where you get the nitpicky, boring stuff.
But you guys have to follow that. You need to know it and you need to follow it.
You have to have a good reason to not follow it.
Exactly.
Yeah. So if somebody comes in
and this is the other thing, like liability. Okay. So obviously your liability insurance is astronomical compared to mine. That's because human life is valued so much more than animal life.
Yeah.
But so we're not talking about, the amount of money here. I'm just talking about whether you're going to be considered culpable or not for medical negligence. So for you guys, it's much more clear cut.
About what?
About whether or not you did. I mean, if you follow evidence-based medicine recommendations and, everything goes to hell and the client dies and you get sued, you followed evidence-based medicine recommendations, and so you're fine.
Not at all.
No, that's not
zero
true.
Way.
Really?
No.
Oh, explain it to me then.
If you're going to say, first of all, that stuff is easy stuff, right? So you say, well, you should be on a statin. You write down, told patients you should be on a statin. First of all, nothing you do exists unless you wrote it down at the time. So imagine trying to have like a 5-minute conversation with somebody about something and then document a 5-minute conversation about something. Like you get a whole bunch of BS words like, patient and I discussed the risks and benefits of blah, blah, blah. And they made a conscious decision not to.
We write the same thing in our medical records.
So you can't count on having followed guidelines that you won't be sued. Because let's say I follow guidelines.
Yeah.
I give the right drugs for community-acquired pneumonia or hospital-acquired pneumonia or sepsis or this or that.
Yes.
Should I have given more fluid? Should I have given the antibiotics faster? Should they have been admitted to the hospital faster? Should, when they had an arrhythmia that everybody has every once in a while, should I have seen that was going to lead to them, going into ventricular fibrillation and dying? Like, should they have been transferred to the ICU an hour earlier? Should they have been, it's so unbelievably complex. It's never about guidelines. I mean, every once in a while, because what'll happen is you never hear about those cases.
You never hear about what cases?
The cases where it's just
thrown out
guidelines, right? I mean, you don't even hear about it because they go to try to find a lawyer and the lawyer looks at the medical record and the medical record says, told the patient they should be on a statin. And that's the end of the case,
Yeah.
period. Like,
Right.
Their complaint was they weren't put on a statin. You documented it. You never heard about it.
That's the same thing in vet med for the veterinary board. Okay. Yeah.
So, and there isn't a board, really. I mean, there is, but that's not the point.
In humans, they go to a lawyer because they want money.
Right.
In veterinary medicine, they need money, so they go to the board.
Yeah. And they'll sue you for anything. Like, they'll sue you just because they had a bad outcome.
Mm-hmm.
Like, they were intubated urgently for shock, and they, have like a vocal cord injury.
Right.
Like
$500,000, please.
Yeah. Or whatever it is,
Thank you. Thank you so much, doctor. Actually, could I go to your hospital and you could intubate me
and give you a
destroy my vocal cords, and then I'll sue your insurance for $500,000.
You're such a good singer.
Thank you.
But yeah, and that would be evidence. You'd play your little things. I sing all the time. It's the only thing that brings me happiness in the world.
That's right.
And you've taken it away from me.
I'm a therapist forever now.
Yeah, exactly.
Yes.
Anyway, but it is what it is. Sometimes people get injured by actual negligence, and that's a thing.
Yes, absolutely.
So, but for the most part, those people don't sue, and the people who do sue aren't actually injured by actual negligence. So, it's one of those things. Like, and we have to be worried all the time about standard of care and documentation. And it's like, so somebody comes in and they have what's clearly seems like pneumonia, right? Well, our ED puts them through, commonly, we'll put them through a CT scanner, and not just a CT scanner, a fine slice CT scanner with contrast, which has its own dangers. You can have an allergic reaction and go into shock, right? And why do they do that? Because it could be a pulmonary embolus, right?
Right.
Is it likely it's a pulmonary embolus? No. Would any doctor in the world who had no threat of being sued scan you?
Right.
No.
Exactly.
Like it's only the threat of being sued that makes you run that test at all.
Absolutely.
And it's like a $3,000 test. Yeah. So don't come to my hospital if you want to, if you don't want to max out your deductible on your insurance.
Right.
Because like you get admitted, it's maxed, period. There's no chance it's not.
Yeah.
So,
because you have to.
Yeah.
And it's not just your hospital. It's any hospital.
And that's before you're even seen by an internal medicine specialist. Yeah. You've already gotten if you come in and you're going to be hospitalized, you've gotten like a $3,500 workup probably before you see me. It's the defensive medicine part drives up costs a lot, a lot. And if you say okay, I work in Flagstaff, Arizona, where, and there's, inner city areas too, right? And in the major cities, if you want to have an idea of what I'm talking about, although it's not so much, but the same. But we have big Native American population, right? And the Native American governments, the Navajo Nation in northern Arizona, and there's the Hopi Nation and the others, but mainly the Navajo Nation, they're poor, right? Like their government is not running over with money, right? And these patients go into their local Indian Health Service hospital, right? And they'll get a presumptive diagnosis of a heart attack for basically no reason, right? Clearly, any reasonable doctor would have not ruled it out, but would not be suspecting it at all, right? And they'll say, oh, my ribs hurt. Well, that's chest pain. Oh, let's check your blood levels for cardiac troponin. Oh, they're slightly elevated. Let's put you on a plane for a $7,000 flight followed by a $20,000 hospitalization at Flagstaff Medical Center. By the time you're done, you're spending $30,000, right? On nothing. And that's $30,000 is probably, you're talking about people who, if someone gave them $500, right? that would make a huge difference in their life, right? So you could give like 60 people a really, really nice bonus Christmas present and like help them out a lot for that money. Or you could or you could do, I'm trying to figure out the calculation, but like probably 750 primary care appointments for that money.
Yes.
Right.
What is your point? What is the point that you're making?
Why are they doing it? It's defensive medicine.
Defensive medicine.
So they send them to us because they don't want to get sued. Right. Okay. They send them to us because, you know, they are so afraid that, you know, they're getting sued. And the thing about it is that in the Navajo Nation, they can't actually sue the doctor. They only sue the hospital. Okay. But even then, like, it's still something you have to, right. You have to testify. It's going to go as like a complaint against you, blah, blah, blah. Right. And especially if you're working with a low income population, they see a lot of times they can see any complication as a chance to double their yearly income, which is a rounding error for some insurance company that's going to pay it out. They'll pay out $15,000 on a malpractice claim anytime. And it wouldn't really be worth your and I while, like, time to spend half a year to try to get $15,000 out of an insurance company. But a lot of places they will. So even in this places like that, you still have to practice this unbelievably nitpicky, unreasonably high level of medicine.
Now, but you told me about a couple of cases that are exactly like that. And you had mentioned that there's a chemistry analyzer that they use to measure troponin over there has a very, very low, so it's got a lot of false positives, so it's got low specificity. Yeah. So their machines
are terrible, and they send us a lot of patients that basically they arrive after their $8,000 flight. Right.
And you rerun
the same
test.
Blood work, and it's normal. And then they stay in the hospital overnight and go home. So now they spent $12,000 for absolutely no reason. Like the machine itself, and this happens all the time, the machine itself would be, $20,000. So for $20,000, you could prevent, 20 of these a year.
Right. So in your hospital, you use a different machine.
Yeah, a good machine.
Yeah, exactly. And this is this was really surprised me though, because I thought in human medicine, like all of your tests were like at the maximum sensitivity and specificity, and there would be no variation, because why would there be? You're working with human beings. You're going to use the best equipment. But here we are on the Navajo Nation, and they've got this crappy, analyzer, old and it gives bad results all the time. Like you get, you may have, it's a 50-50 chance. Like, should I flip a coin? I could be right just as many times as this machine, right? So, but in veterinary medicine, there's a lot more variability in terms of, we have a lot of different companies offering the same tests, but not all of them are as accurate as, but you guys pay a lot more attention to that than we do, I have to say. And
at a real hospital, you'll only have good machines.
Exactly. And the doctors don't even need to worry about that, except in your decision-making as to which test to run, blah, blah, blah. But my point is, it was really surprising to me to find out that there was this human hospital, that was using a machine that had really low specificity.
Yeah.
But it's just because they can't afford any better. But in veterinary medicine, I mean, there's some, that's why you have to look at sensitivity, specificity. So these people are going to, like future veterinarians listening, they're going to go out and work for practices. And I think it matters what machines you're using to measure chemistry, and because they are not all the same. What snap tests or what in-house tests are you using to measure heartworm, parvo, stuff like that? Because they are not all equal, and practices will often buy these or rent the machines based purely on, this one's cheaper than that one. Well, I'm going to tell you that shouldn't be the only consideration, because if it's cheap and it doesn't give you accurate results, then it's worthless. So it doesn't matter that you saved money. So I do think this is something that we should pay more attention to in veterinary medicine. Anything else that you want to talk about in terms of similarities, differences between vet med and human med?
Money.
Oh God, yeah, We can't really get away without talking about that, can we?
No. It's much more money in human medicine. And especially if you're a specialist. I mean, you can make lots of money if you want to, if that's your primary goal. What I've noticed is that let's see, how politically incorrect can I be?
I don't know. Give it a try.
Veterinary medicine is a lot of women.
Yes.
Right?
Yes.
Yeah.
Yes. And this is going to be good.
And they don't seem to want to open up a lot of practices.
Right.
So they're all working for other people.
Mm-hmm.
And you don't make money in veterinary medicine working for other people as much as you do in human medicine. And even in human medicine, you make more on your own.
Mm-hmm.
But it's not the same spread.
Yeah.
And when you're in human medicine, it's more of a lifestyle choice too.
Mm-hmm.
Like you work for somebody else because it's easy.
Mm-hmm.
So how many practices did you work for? And how many of them were run by women, owned by women? Like there was one that had one person on the board who was a woman, right?
Oh, you're talking about the ER?
Yeah, the ER had one woman, right?
That's right. There might have been, yeah.
Yeah. But basically, it's all men, and not all, but there's a lot of men owning practices,
mm-hmm.
and that's because they want to make money,
mm-hmm.
right? So they are seeking out that that place to go.
Yeah.
Uh-huh. And they're like, okay, well, the only way I can make the money I want to make is to run a practice, which is a really, big risk. It's a big job. It does a thing, right?
That's pretty much all they can do.
You can't be part-time.
No, you can't be part-time. In fact, you're not even full-time. I'd say you're double-time.
Right. So,
if you're a practice owner.
Yeah.
So guess what? You're not doing the grocery shopping and the laundry and looking after a household and looking after everybody else in the household.
Yeah.
So that's why. Well, I'm just saying, if we're going to be, honest about it, yes, it's true. More men own practices than women, but it's also true that women tend to feel responsible for everything else that's going on in life, whereas men who run practices, if they have a wife, they have the luxury of depending on somebody else to take care of all that stuff.
Yeah, or they just pay someone. But,
mm-hmm. Yeah.
It's one of those things. There's plenty of women practice owners in human medicine. It's not as many as men, but there's quite a few of them. Mm-hmm. And, they're partners in a partnership, mm-hmm. right? And something about veterinary medicine is special in that the
people going into it don't care about money.
Well, they may care about money, but it's not their primary concern.
Mm-hmm.
You see a lot more lifestyle decisions being made.
Mm-hmm.
I don't know any doctors who go half-time, right? But
female doctors?
Even female doctors, yeah. I basically...
female MDs?
Yeah, female MDs. Very few of them go half-time,
mm-hmm.
right? All I've seen in veterinary medicine
mm-hmm.
is everybody wants to be on halftime or less,
mm-hmm.
right? They all want to be on halftime. They all want to be it's almost like a part-time job, right? And that's why this part of the reason why there aren't as many. There's a shortage of veterinarians despite having tons and tons of. Part of it is I don't think that at some point it's worth it economically to them, right? So, and this is where I'm going to go with this,
mm-hmm.
which is...
I think you're right.
So what's the difference between a starting veterinarian salary and half a starting veterinarian salary, right? If you're in a relationship with somebody else who's making money,
mm-hmm.
right? So you're talking about going from, what's a starting veterinarian salary?
$75,000.
$75,000, right? So after taxes, $60,000.
Mm-hmm.
Right? You cut your hours in half, you're in a lower tax bracket, you probably make $37,000,
mm-hmm.
right? So now you're talking about, well, the difference is $23,000.
That's true.
Right? Your husband or wife,
mm-hmm.
if you're a veterinarian, could be making that much money too. So you're talking about you're talking about going from a family income of $125,000 to a family income of $98,000, right? I'm saying a person who is a veterinarian who is married to another professional or semi-professional, right? Who's going to be making probably at least as much as they are, right? If they cut their hours in half, you're only reducing your family income by a quarter.
Yeah.
Right? Undeniable. So you reduce your family income by a quarter, and all of a sudden you have all this quality of life. You can take care of your kids. You can start your, do your art projects. You can, do whatever you want to do. You can cook more dinners. All of a sudden you're eating out less. It really doesn't even cost you a quarter of your family income because you're paying less. You're eating out less. You're paying less for maids, this, that, the other thing, right? In human medicine, you're talking about cutting, $125,000 out of your income minimum because
go half time.
Yeah. And
yes, exactly.
For $125,000, you can hire a couple of maids.
Oh my God,
right?
exactly.
So you're talking about there's no point in
and a cook.
Right. So the money is different in that. And this is going to be a long thing, but the money, this is a long segment to basically say money is opportunity cost, right? What else could you be doing with that time? And is whatever else you could be doing worth that much money?
Yes.
And in human medicine, it's just not.
Yeah.
You have to work, right? Yeah. Because it's worth it to work.
Right. It's worth it to work. Exactly.
Yeah. So if you're saying the way to make the opportunity cost worth it is to have your own practice or to really be dedicated or to be single, right? If you're single and you're on, the starting veterinarian salary, you're doing fine. You can take care of yourself. You can eat and you're fine, right? You don't have to make dinner for anybody. You don't have to do anything like that. You can dedicate yourself to your work. But
you can pick up extra shifts.
You can pick up extra shifts. You can do
ER relief shifts. And if you're single and you have no kids.
It can be a good lifestyle. You can have a good work-life balance because when you go home, you don't have any other responsibilities.
Yeah.
Single and no kids on that salary is great. And, you end up with the situation of being locked in as a human physician, right? You're locked in by, you end up setting up a lifestyle such that you need the money to pay for the lifestyle, right? So if you have your student loans and your house and the things you want to have, you are stuck. You can't cut enough out of your you can't cut enough out of your salary to,
you can't cut enough from the budget.
You can't cut enough from the budget to go half-time. You just can't. So, you're kind of there.
Yeah. It's interesting that you say that MD work because it's worth it to work.
Yeah.
Yeah. And the thing is, I know you're not saying that women are lazy, but because women in human medicine are not going half-time. The difference is, but this is really interesting because I've seen you come home from a hard day and I see the stress on your face. And because I'm a veterinary medical doctor, I know what it's like to care, And some people can say animals don't matter as much. Well, to me, they do. My patients matter a tremendous amount to me. So the emotional and psychological strain of the responsibility that a medical doctor carries is enormous. I've seen it on your face and I felt it myself. The difference is for you, because of the amount of money that you make, it's worth it.
Well, yeah. And I could work less and make less money, or I could get a lifestyle job and make less money. But I think that in the end, it just says, you can't, you can do a lot with the money in human medicine.
Mm-hmm. But what I'm saying is, like, in veterinary medicine, we have the same emotional and intellectual and psychological strain.
Yeah.
With a lot less reward.
Yeah.
A lot less.
Yeah.
So I think what you're saying is true. Like, people are saying, it's not worth it. And proportionally, because the salary is so low, the difference between full-time and part-time, meh.
Yeah, I mean, and it's a big difference if you're single, right? It's half the money.
Mm-hmm. Yeah.
Right. But, very few people who are single are going half time.
Mm-hmm. That's true. Right. But they don't have a reason to go half time.
Right. They don't have anything, they don't
They're
have
fine
any
to work
other
all the
things.
time.
Yeah.
But I mean, but also, like, women want to get married and women, want to have families. So
yeah.
I think, are we saying that women should go into human medicine instead?
Well, it depends.
Mm-hmm.
Depends on what you want to do.
Mm-hmm.
So I think that having seen what you do and having seen what I do, it'd be hard for me to say that logically anybody should go into veterinary medicine. So it's
wow.
It's and here's why. All right. You are working with lesser technology
mm-hmm.
in a lesser environment
mm-hmm.
with a lot of financial stress that we don't have to deal with
mm-hmm.
in terms of, like, the patients not being able to pay for the workup.
Mm-hmm.
So you have to, from a medicine perspective, you have to worry about what workup can I run versus what workup should I run.
Mm-hmm.
Then you get the diagnosis and people can't pay to treat, right? The complex diagnoses, right?
Mm-hmm.
Or they can, right? But, every once in a while, right? So you see, most people who have a dog that needs a hip replacement, the dog just can't walk anymore, and then they put them down, right? Because mm-hmm. they don't have $5,000
mm-hmm.
for the hip replacement.
Yeah.
So in that sense, I don't think anybody, and then on top of all that, the pay is at least a third, like at most a third of what you get paid in human medicine. So
yeah.
Why should anybody do it?
Right.
And then the answer is, well, you have to want to do it specifically.
Mm-hmm.
So if you say, well, there's no logically good reason to do veterinary medicine over human medicine at all.
Like, logical reason.
There's no logical reason to do it. Why are you doing it? Because you want to do it. Like, there's no logical reason to be a portrait painting artist either.
Mm-hmm.
There's no logical reason to be, a concert pianist unless you started at age 4 and you're going to work in, in a big place in New York, right?
Mm-hmm.
Like 95% of those people,
Don't
never even get into the middle class,
right?
Well, there's no reason to do that. Well, the reason to do it would be, I can't see myself doing anything else but that.
Yes.
I would do it if it paid nothing. Mm-hmm. I would do it as a volunteer if it didn't exist.
Mm-hmm.
If there was no such thing as veterinarians, I would do it, and I would go in and volunteer and do it.
Mm-hmm.
Then you should do it. Mm-hmm. But otherwise, why are you doing it? you're.
But this is what a lot of veterinarians say. Like, I can't see myself doing anything else. And
yeah, and that's why. And that's, I can't see myself doing anything else but being a opera singer. Right. Well, I want to sing.
Uh-huh.
I have to sing. It's in my heart.
Yes.
Right. That's it.
Yeah. Mm-hmm.
If it's in your heart, then that's it. I went into human medicine for a completely different reason. Yeah. I went into human medicine because it was something that wasn't going to get boring.
Mm-hmm.
Right. I thought.
And veterinary medicine doesn't.
Right.
Well, I mean.
But I went into it because it wasn't going to get boring.
Mm-hmm.
And it was well paying,
mm-hmm.
and it had a science component, which I like.
Mm-hmm.
And, it was kind of geeky too, which is something that I am.
Mm-hmm.
So you end up with you end up with just that.
Mm-hmm.
I didn't go into it because like a pediatrician or something. I love and want to save kids from pain and harm, and even without that sort of inner drive that I couldn't have done anything else with my life.
Mm-hmm.
It's a satisfying career,
mm-hmm.
right?
Mm-hmm.
Like, would I like to be a concert pianist if it paid the same amount? Yes. But like, I don't know how to play the piano and I learn now. But what I'm trying to say is there's a good reason to be a human physician. And even if you just think it's interesting and just think it's interesting and want to make money.
Right. You didn't do it because you wanted to save the world.
Right. No. And you don't have to.
Yeah.
And to be a vet, I think you have to want to be a vet and only a vet.
Mm-hmm.
Otherwise, you're going to vet school, which is harder to get into than med school,
mm-hmm.
right?
Mm-hmm.
You're still doing all the same stuff.
Mm-hmm.
It can cost just as much, right? So you still have
Mm-hmm.
the same student loan payment in most cases.
Mm-hmm.
And at the end of it, you're on the salary scale of, some people who went to trade school. So
it's true. It's true. Dental hygienists.
Yeah. Dental hygienists. Or you can, say, I want to make a ton of money as a vet. So I'm going to own a practice and then I'm going to branch a second practice and I'm going to end up being a CEO, but in which case just go to business school. Like, what? Yeah. So
why does this sound depressing?
Yeah. Hi. No. Hi, all you veterinarians. No. I don't see why people logically do it, and that's generally when you say, well, then it's not logical. It's because you want it.
Mm-hmm, mm-hmm.
And all those people out there who are listening to me probably are people who want it or think they want it.
You're right. Yeah. Well, but the DVM is really diverse. I mean, so like, if I wanted to open my own practice and make tons of money, I could do it a lot more easily than you could.
Starting a practice?
Yeah.
Yeah, you need to sort of spread the risk around a little as a human doc. Starting up a new practice is more expensive. Means hiring much more people because there's the administrative side of it too.
Because of all the insurance forms.
And insurance and all that. And, you probably need to do it with a couple other people, usually. Mm-hmm. So you usually send it up as a partnership.
Mm-hmm. Mm-hmm. Yeah. And I mean, you guys have a lot more rules that you have to follow. So you definitely need more administrative staff, and you need much more qualified administrative staff because those rules are serious.
Yeah. And you need more qualified if you're going to have nurses and things like that.
Right. So
yeah.
If you are an entrepreneur, then I think veterinary medicine might be the better route to take. And also we don't lose 3 to 7 years of a required residency.
Right.
So.
Yeah. And you're building up student loan interest during that time.
Mm-hmm.
So you're setting if you wanted to make money in veterinary medicine, it seems like there's a pretty clear path.
Mm-hmm.
You just have to find a place that's underserved and has enough money to, and enough animals.
Yeah. Right? I mean, there's still risk involved. Sure. Yeah. It's not a sure thing. Unlike annual salary.
Yeah. And I think it would be very hard for me to switch over to being a business owner too.
Mm-hmm.
So I think it'd be a little easier for vets to switch over if they wanted to.
Why?
Huh?
Why would it be easier for a vet to switch over to being a business owner?
Well, how much money do you need to make? If you're in a situation where it's the same thing I'm talking about before.
Oh, I see. Yes. Because for you to start up your own business and forgo your annual salary for however long it takes you to build that business, at minimum, a couple of years.
So it costs $500,000. Probably more like $750,000 to start the practice, and then you foregoing a salary for a couple of years, really.
Yeah. So then you're in the hole.
You're in the whole
lot.
A big chunk.
Yeah. So that makes a lot of sense.
So it's opportunity cost too, right? Mm-hmm. Every hour you're not working, you're giving up an hour salary,
Yeah.
So
you'd be paying a lot more in opportunity costs than a veterinarian would
yes.
to start a practice.
And actual costs, hiring costs, the risk of the hiring costs.
Yeah.
Like, it seems like to me that if you wanted to start a basic vet practice, you're, not fancy. You're going to start slow with lower risk as you can. You have like an office you can rent, a vet tech, probably $60,000 worth of diagnostic equipment, and you can start seeing patients, right? Some computers. So you're talking about, you could hypothetically do it for a couple $100,000.
Yeah.
And that's great, right? And then you can expand, right? You can't do that in our business at all. Like, you have to hire more people and promise them salary and benefits.
Yeah.
You don't need the equipment, but you do need you need more insurance. You need, there's all sorts of stuff.
Now, as a small business owner, you wouldn't have to give them insurance and retirement, but you need like highly qualified people, and therefore you have to offer those things to get those people.
Yeah. And it's tough, but I know some people who have started a practice, but not very many in the last decade. It's much harder to do.
Yeah. So that's one advantage of veterinary medicine. If you do want to open your own practice, you've got an entrepreneurial spirit, then.
Yeah.
And I also wonder, like, I feel like, and I could be wrong, but I do feel like the DVM degree offers a lot more diversity. You can do a lot more with a DVM degree than you can with an MD degree. I may be wrong, but so One Health, Zoonotics, both of us, MD, DVM, yes.
What?
One Health, talking about like zoonotics.
Oh, yes. Okay, go ahead.
Infectious disease that affects humans and animals. And, public health, MDs and DVMs both are involved in public health. Government, pharmaceuticals, MDs, DVMs, both.
Yeah.
But DVMs also can work in like wildlife management and zoo medicine and farm animal medicine.
Oh, yeah. Yeah. There's a lot of diversity there.
Yeah. So an MD degree is diverse in that you can do government, pharmaceutical,
research,
teaching, just like DVMs can. But we have more species and more of what we do, depending on what, subfield you go into in veterinary medicine, there's more overlap with environmental issues, like what Dr. Simeon is doing with, the health of the oceans and the marine mammals being sentinels for that. And she's working with biologists and oceanographers and all that stuff. So
yeah, that's a very interesting and small area of that.
It is small, it may build. I mean, it may grow. I could see how it could grow. I mean, the more we learn about like studying these different species in the wild and how changes in those species reflect changes in the environment.
Oh yeah.
I mean,
I think it would be very interesting to see how that goes in the future. I think that you're in the same, let's see, how could I say the difference? You do a lot. There's a lot more different areas of veterinary medicine. In human medicine, it's more of like different specialties, or you could be an administrator.
Right.
Like that's the other thing.
Right.
And that's fine too.
There are some vets who are administrators.
Yeah. You talked to one, right?
I did. Yeah.
What was his name?
Dr. Timothy Hunt.
Yeah.
Yeah. He's the COO of a chain of hospitals.
You can't seem to say enough about that guy.
I have a professional question.
You have a professional question on Dr. Hunt?
I wanted him to be my boss.
Ah, yes.
Yeah.
Well, there you go.
Like that, I've said it before, but like my wish for every future veterinarian is to have Dr. Hunt as the boss.
Yeah.
He's wonderful.
Well, that's good.
But yeah, so I don't think it's as common or even as lucrative as being in like an MD, in the administration of a hospital.
Yeah.
Nowhere near, but there are some, and so there's also DVMs who are climbing the corporate ladder and the corporate chains.
Oh, sure. Yeah.
Yeah,
and I always think on both sides, human and that side, I always think, why didn't you just go to business school? You'd have saved yourself $400,000 and then made more money.
But then you would just be contributing to the problem, because this is part of the problem in human medicine that human medical doctors complain about all the time. It's not as much of a problem in veterinary medicine, but it is a problem. That is that people who don't know anything about medicine are making the rules for people to practice medicine by, and it's a mess. It's ludicrous.
Yeah.
So I think they need to be MDs.
Okay.
I think it's good that they're MDs.
MD administrator.
I think it's better than having an MBA administrator.
That's true.
And I don't even think that if you have an MD and an MBA, but you never practiced as an MD, that's as good.
I see.
You had to have practiced medicine
to
be a good administrator.
I think you're right.
Mm-hmm.
I think that's definitely true.
Yeah.
So, I don't know.
Hopefully we didn't depress too many people, but it was an honest and candid conversation.
Yes. And I'm not saying women are lazy. Come on.
Oh, no, we wouldn't do.
No, genuinely not.
Well, they're not lazy. My God, women are not lazy.
I know. I just don't want to leave anyone with the impression that I'm saying.
It's just that we do so many different things, So, and you're right. Opportunity cost, that plays into it. And there was an article that I can't remember where I saw it. It might have been Veterinary Information Network, but somebody was saying exactly that. Why is there a shortage of veterinarians? Well, because they've come to the conclusion that it isn't worth it to them to work, full time because you're not paying enough.
There you go.
You're not paying enough and you're not offering enough. So, anyway. So, thank you.
Oh, you're quite welcome.
Mr. MD. It was very enjoyable.
That's Dr. MD to you.
But I had a good time.
Me too.
All right. Thanks. P.S. There's one more thing that I wanted to talk about.
She wants to talk about the big red button.
The big red button, yes. Because when I worked in the ER, it was just me all by myself in the middle of the night with critical patients and surgeries and people coming in with sick animals all the time. Mm-hmm. And I didn't it was just me and the internet. I mean, I could get on the Veterinary Information Network and try to look stuff up. But when my husband was on his rotation, was it ER or was it ICU?
No, it's residency.
In
ICU.
Residency. He was on an ICU residency. And I thought, okay, now he's going to be doing like what I was doing when I was an ER vet. And I was like, well, what do you do? It's the middle of the night. And what if you have questions? What do you think he would do? Tell us. What would you do?
It's not if I have questions. I mean, I suppose I could use it for that. But mainly it's if there's something I can't handle.
Oh, well,
right.
Yes. No, there was lots of stuff that I really couldn't handle.
Yeah, absolutely. So basically,
I had to handle
on the wall of the ICU in every room.
In every room. Not just like in the hospital, every room. Yes.
In every room in the ICU, which was like 35 rooms, there was a big red button on the wall. Big red button. And when you press the big red button on the wall,
I would have loved to have a big red button.
Camera swings down from the ceiling, points at the patient, and it says, and the guy, and like, it's almost always a guy because they're like working at night and they're like nocturnal, like people who sit in a dark room. And I don't think it's, anyway, they were almost all men, but they were like, it was like, tell me the situation, like booms out of loudspeakers in the room, and you and they had access to the EMR and the telemetry, the medical record and the telemetry and the current patient, and they could zoom and pan and tilt this camera, and they could like point it on a patient, and also simultaneously it would set off the alarm. So like 4 3 or 4 experienced nurses and respiratory therapists would all of a sudden like come out of the woodwork and show up in the ICU. So they would be, if it was a code, they'd be like bagging the patients. If it was like a rapid response situation where the patient was becoming hypotensive and you didn't know what was going on, they would like draw blood for you. They'd do all this and that. And meanwhile, a experienced board certified critical care specialist would be like booming their voice over the loudspeakers and telling you what you could actually do and giving you second opinions.
Mm-hmm.
If you were alone in the hospital and 2 patients were crashing at the same time, they could run one of the cases with a nurse.
God.
Yeah. Or a respiratory therapist was better because they do better exams than the nurses.
Yeah.
But they could run one of your cases with a respiratory therapist and you could just focus on the other one.
The big red button.
The big red button.
I did not have a big red button. That's the other difference.
Yes. The big red button.
I had to tell you about that.
Give me the situation.